decision. I'm Bethany Kwan, I'm the director of the education program at Accords. Anyone want a quick update on what Accords is? Okay, so welcome. How many of you here have been to a previous Science of Patient-Centered Decisions seminar? Most of you, but also some of you haven't. So we spent the first few seminars in this series introducing the general idea of decision-making, judgment, emotion, and now we're going into some case examples, specific studies and areas of work around shared decision-making. And today we have here two the leaders of the program for patient-centered decisions in our course, Dr. Dan Matlock and Mary Allen, to talk about their work in intracardiac defibrillators.
Plannable. Yeah, hard stuff.
And LVADs. It's like left ventricular something, something. So they're going to be talking about their work in that area. So I'll turn it over to Dr.
Okay, thank you. Yeah, so we've been. Yeah, so we planned the seminar series, and the first few talks were some basic talks, and then we thought the last few talks could be just diving in more deeply into some examples. If you've seen either me or Larry talk before, we probably are using slides from other talks that just sort of shortened down and focusing on some different things around some of the research. So for some of you, none of this will be new, but hopefully the context and the juxtaposition of these two will create some new thoughts and things around implementing and doing shared decision-making with different decisions, even in fairly similar context. So I'll start with implantable defibrillators, and then Larry's going to talk about ventricular assist devices. These are both things done for patients with heart failure. ICDs are often done when people aren't near the end of life or aren't really sick, and while LVADs are usually done when people are pretty sick, often in the ICU. So that's one difference in context between these two decisions. This is a picture, a free Google image of a guy that reminds me of a patient, because I didn't take a picture of him. In 2002, when I was a resident, and this was when defibrillators, ICDs, were kind of new, and he came into the hospital. He was a farmer from the San Luis Valley. He said he didn't want a lot of things done. He was admitted for heart failure. He had kidney failure, all kinds of things going on. And he just wanted to go back home to the farm. And then the next morning, I was at one of the private hospitals when I was a resident, where we didn't really have much agency as residents. We just kind of watched the private docs do medicine, and we helped them do paperwork. In contrast to some of the hospitals like Denver Health, where we kind of did everything with very little oversight. But he was whisked away the next morning. And I went to look and asked the nurse where he was, and he was down in the lab getting one of these defibrillators. And I didn't really know, kind of knew what they were, but I didn't know any of the data. There had only been a couple trials, big trials at that point. So I started learning about it. And I talked to him afterwards, and he had no idea what this was for. He was told he had to have it. And I'd always regretted not having more of a discussion, making sure that he knew this thing was in his body that could shock him. And that's kind of where I started getting interested in defibrillators. And this picture on the right, really, you're right, is what a defibrillator looks like. So for those who don't know, they're just like little pacemakers. They're about the size of a pacemaker that's set under the skin, except they act very differently. They sense the heart, and when the heart goes into a dangerous rhythm, they deliver a shock to try and restore a regular rhythm, just like you see on TV with the external pads, which stays clear, and this is just an internal version of that. These things are wildly effective at preventing death. This is the big SCUD-HEF trial that convinced Medicare that they should fund these things. Over 5 years, there's 3 arms here. There's the ICD arm, the control arm, and then there's this, you could ignore this arm. At the time they started this trial in the late 90s, there was a question of whether an antiarrhythmic drug would be just as good as a defibrillator. And it wasn't, it was as good as a placebo. But over 5 years, you see there's this large 7% absolute risk reduction in death from getting one of these devices. So this is big. This is bigger than anything I do in primary care with blood pressure or cholesterol. For preventive medicine, this is a very beneficial thing. And these were people with heart failure. These were people, defibrillators were originally developed for people who passed out at the airport from sublethal arrhythmia or resuscitated, and they've proven themselves to be at high risk of having another arrhythmia. So they get this to prevent it. This, they just took a population of people with heart failure and gave them devices because they know that population is high risk, but these were people who hadn't actually had any sort of prior event, and it was still beneficial. They come with lots of harms. This is where I'm segueing into the shared decision-making to talk about the trade-offs. Yeah, it's beneficial, but they come with this list of harms, which I won't go through. Maybe I'll mention a couple, particularly this potential suffering at the end of life. These things are beneficial to prevent death, to prevent sudden death. There was a survey that Nate Goldstein did where half of the hospices in the country had a patient in hospice with a defibrillator that wasn't turned off. And half the hospices, the patient gets shocked by their defibrillator while they're in hospice dying of some other cause. That's getting better as defibrillators have become more common and hospices are aware of them. But in the old days, it would be something like a patient would get cancer, go to hospice, and the poor hospice team or nurse didn't realize that this pacemaker was actually not a pacemaker, but a defibrillator. And then the families around them standing vigil, and then they think they're dying, and then they start getting shocked. Medicine doesn't get much worse than that, even though this is a good thing. So there's trade-offs with this device. And it gets into what I think the big trade-off is, which is this basically this mode of dying. You often hear patients with heart failure, and they're going through this up and down path, or they're going through this heart failure, and while they're still feeling pretty good, they have sudden death. And defibrillators only treat this. And for me, if I had heart failure with 3 young daughters, I might not want this. I wouldn't want this. I'd get a defibrillator. But I work in the seniors clinic and see a lot of old folks, and there can get to be a time in life when people will say, you know what, if I was to die suddenly, that would be fine. Don't do this. And so that's where I get into arguing that there's a trade-off with these defibrillators, because everybody's different. So what we've done in our group is we've developed decision aids to try and support shared decision making. Decision aids aren't shared decision making. Decision aids support shared decision making. Those are two separate. Shared decision making is an intimate interaction between a patient and family and their clinicians. That's a shared decision. So we make tools to try and support and encourage shared decision making. What a decision aid is, it provides information about options. These are from the International Patient Decision Aid Standards. Present probabilities in some sort of unbiased and understandable way. Provide some sort of method for clarifying values, and this is the least developed method for a decision aid. This can be done implicitly or explicitly. Some people use things like analytic hierarchy or multi-component decision analysis and do really quantitative ways of helping people clarify their values. We've done some things in videos where we show competing narratives, which is one of these implicit ways where people can say, oh, here's somebody with one, here's somebody without one. Now, you've heard a couple experiences, what's right for you. I think there's pros and cons to both. And then some sort of structured guidance to deliberation and communication. Decision aids are wildly effective when done in these small little efficacy trials, or some of these are large efficacy trials. They improve knowledge, doctor-patient communication. This is from a Cochrane review. Patient involvement in the decision, satisfaction, value treatment concordance. Just keep mind of the time here. They lower conflict, they lower regret, and they lower the proportion of people undecided. And so this is a very complicated schematic of basically what we go through when we develop one of these things. You view the evidence that's out there. Then you do some sort of observation or needs assessment. We interview patients and docs, or you observe encounters and see how it's going. And then from the evidence and what you see as the needs of the decision, you make a prototype. And then we iterate that. And one of the things that our group, I think, has thought about is that this is really where the meat is. The first decision aid I made with defibrillators, I spent 3 years doing these qualitative interviews. Then I made a tool, and then I showed it to docs, and they're like, I'm never going to use this. I would never show this to my patient. It gets into this need for user-centered design. So we argue when I write a grant, I say, we base this on decision theory, and international patient decision aid standards. But then we leave those and go through this iterative user-centered design process to design something that meets the needs of people. And this is my concern with some of those quantitative values clarification exercises. It's hard enough to get a one-page thing in a clinical setting, much less something more complicated. It's an implementation decision. But I think this is, I can argue using a different frame, this is designing for dissemination, designing something that will be used by the ultimate end users and thinking about that really early. And then once we modify that, we get a final decision aid. So this, excuse me, I'm just a little stuffy, probably from the cold. This is our website. Larry and I have a website with a bunch of our decision aids that we've been making for the past few years. This is linked to the ICD page. We have a video and a paper version, and then we have the content that you can scroll through on the website. Our first PCORD grant around this, we said we're going to make a long paper version, a short paper version, a video, and a website. And then we gave these to patients, and they liked having the video. They liked the video the best, and they liked having the longer paper version to kind of carry around. Some people liked the shorter paper version. They all liked the website, but nobody used it. Nobody wanted to use it. So we spent all this money on this interactive website, and that nobody used. So it was kind of great. It's great because now we're not spending all this money on these interactive websites anymore. Although I think that will continue to change as technology continues to advance. That was almost 10 years ago now at the beginning of the story. But we're making things web available, but we're not doing a lot of interactivity or recording a lot of data. And that's also an implementation decision, just trying to get something that people will use. Here's some things in our paper so you can get a flavor of what some of these things look like. I showed you those competing paths, and we're trying to explain to people that there are competing paths. If you choose one path with a defibrillator and one path without a defibrillator, things can look a little different. And in this graph over here, this is called a pictograph or an icon array. Actually, Brian Zippenfisher at Michigan has this great website called iconarray.com, where you can go on and you put in numbers and it'll spit out a picture for you. You can make your own icon arrays if you're doing decision tools of some kind. But there's data that people are much more likely to understand data. This is the same data I showed you from that trial earlier. Over 5 years, 7% absolute risk reduction goes from 36 to 29. And you show people this, if I tell them a percentage, people are much less likely to understand that if you show them something like this, they're much more likely to answer a knowledge question correct. This is how you use some of the theory to inform the tool we developed. Now I'll dig into these paths a little bit in the subsequent slide, but there it is, a little close-up. And both Gretchen Schwartz, me in my first talk, and Laura Scherer in her talk talks about framing effects, because they're big behavioral economic things that influence decisions. So we're trying to frame it both ways. 29 die, 71 live. 36 die, 64 live. So we're trying to avoid framing effects. Larry will talk about the LVAD tool, but there we framed it a little differently. We just framed them both options around life. But we're trying to balance framing so that we don't influence decisions one way or the other. And then we also use narratives. This is part of the values clarification piece. This is not a this is one of those qualitative values clarification methods, but here's a quote. And I think this plays a little better in the video than on paper. But we wanted to at least show it on paper. But here's a quote: "I'm not ready to die. I have so much I'm trying to stay alive for. Even if it means getting shot, I'm willing to do anything that can help me live longer." So that's the right decision for that person would be to get a defibrillator. Or, "I've lived a good life. The idea of dying quickly sounds like a painless way to go. I always said I hope to die in my sleep. Going through surgery and getting shot is not the kind of money." So we tried to frame them both. These are both reasonable decisions. It's not life versus death. It's two reasonable options. And one you may not lose on, but they're both reasonable. And then the person can read these narratives and try and decide what's right for them. And we need a lot more research, basic research and decision-making around values clarification. Actually, Chris Konopke, one of the former postdoc and now junior faculty here, he has an AHA career development award around different methods of values clarification. How do you help people do these things? Beth Schaefer's been picking on me a little bit about different ways of doing values clarification around LVADs. And we need so much more research in this area. Here's some little clips from our video. I'm not going to play any of these, but we have a bunch of people. Some of you might recognize Fred Masudi, one of the cardiologists here, Paul Verosi, an electrophysiologist at the VA. And these are some of the patients that are in the video talking about their different experiences and decisions.
Actually, a patient you and I both took care of.
Oh yeah, oops. Yeah, Larry and I share one of these patients, actually. And narratives are funny in decision aids. They can be very biasing. So we try to use process narratives and experience narratives. We try to avoid outcome narratives. We don't, if somebody says this was the best thing I've ever done and everybody should get this, that's not a narrative we would include in the decision aid because there's data that that's going to bias people. We studied this in a little pilot trial. We were shooting to enroll around 60. We got about 20 because we had to redo the whole decision aids in the middle of the trial because we found out that we learned some things in the pilot. I won't go into the details there. But we did find that they were feasible, and the best way was utilizing clinical staff to deliver these tools. Patients felt the decision aids were helpful and balanced. They recommended them to others. There were non-significant trends and improvement in the decision. We were obviously way underpowered to really test those things. And patients preferred the paper and the video, not the website. And clinicians liked them in general, but they wanted decision aids for re-implantation. This is the patient who got the defibrillator, and now they're 7 years later, the battery's running out, and they need a new one. And that's where they struggle more because that's when people are often getting older and sicker and the decision starts having more equipoise. But, or this other type of pacemaker that goes with the defibrillator sometimes. But implementation of these things is really hard. Questions like who's going to deliver it? Is it going to be the provider or a staff member? How will you deliver it? Electronically with the electronic health record in the patient portal and email? Is it going to be a printed or a DVD version? These are all questions that make this really hard. And then medical decisions, different decisions require different depths of deliberation. We've got this ICD tool. It's a paper tool and a 15-minute video. We have a 26-minute video for the next one, and some patients have told us they wish that one was longer. Nobody here is telling us they wish this was longer. So you can't, one size decision aid doesn't fit all. And then when will you deliver it? When is the person actually in their head making that decision? You get into these outpatient decisions, it's actually kind of hard to know even when this tool is going to actually help them through their process. There's been some recent studies in the heart space of doing it right when they're signing the consent before they go get a cath. And not surprisingly, nobody's changing any decisions because they've kind of already decided. That's why they're there with the gown and their bottom hanging out. They're going to go through the procedure. It's kind of hard to do anything different then. But it's really hard. And this is systematic review of implementation of decision tools, and this you can see by the title, many miles to go. They're really hard to implement. So that's where our group has gotten a strong relationship with the Accords D&I team because a lot of the work we're doing lately is how do we implement these things. And for those who do NHLBI research or work with heart conditions, the NHLBI is very interested in implementation science. All of a sudden, they have this new CITRIS group, Center for Translation Research and Implementation Science. Some people here on the K-12 program, they funded 9 of these around, or 10 of these or something like that, around 10 of these around the country. They're investing in implementation science. So that's also who's funding our R01 to study these ICD tools. We're studying them in a combined effectiveness implementation hybrid trial. We're using a Stepwedge Design. We have 6 sites. We're rolling these out. Every 5 months, a new site gets the decision tool. We just finished the second rollout. Second rollout. That's going on right now. We have our 3rd rollout in June this summer. And then you compare, you randomize when people get the rollout. And the idea is that randomizing when people get it somehow control for the secular trends of pre-post trials. But some of these other designs might be better in different contexts, but here we thought this was the best design. We didn't want a patient level randomization because we think there'll be some diffusion of treatment effects into the control. This is a shared decision. It's not just one patient taking a medicine or a placebo. It's this conversation. So you can't really randomize that easily. We could have done a cluster trial where 3 sites get the intermission, 3 sites get the control, but that's not very well powered, and we can't really afford many more sites than that for at least this context. So we chose this Stepwedge design. There's some big disadvantages of it. The idea is it controls for secular trends, but I don't think that's completely true. And I'll talk about Medicare has mandated shared decision-making for ICDs since we got the grant. So all of those control groups are now getting interventions. We've had a long conversation about that. I won't get into. But we're using the Re-Aim framework for the evaluation of this. And just to go through this briefly, REACH is the number who get the intervention divided by the number eligible for the intervention. This is the easiest one conceptually. And it's really hard because defining that denominator of who's eligible, it was hard in the LVAD trial where people are in the ICU. And here in the outpatient setting, it's really hard to know who's eligible. So we're looking at this in a few ways, but at least of the people who consent to our trial, we'll see that that'll be our denominator. And then of those who got the intervention, that'll be our numerator. So we'll get REACH of the consented patients for this. And then we're trying to explore ways to look at REACH in other ways, such as chart review and documentation of shared decision-making. But this is hard. REACH is really hard to get at. Effectiveness, we're using decision quality, which is this dual construct of knowledge and value concordance. Is a treatment. I'll actually let Larry talk about that more. I imagine he's got some slides on that on the LVAD. And then some secondary outcomes, conflict, regret, and preferences. We're looking at adoption and implementation qualitatively. Adoption is a little bit artificial in a trial like this. Adoption is a site level or clinician level. Did they adopt it? And we approached 7 sites and 6 agreed. So our adoption there would be 86% or whatever that is, 83 1/3% for adoption at the site level. But we're also looking at adoption at the clinic level. Are there going to be some clinicians in the clinic who just refuse to do this at all or not? And then implementation, we'll try and decide what worked, what didn't work. We'll look at it that way. And then maintenance, at the end of the trial, when we're in our analytic phase, we'll go back to the sites and say, hey, are you still using this? And you can see how this kind of got messed up with this Medicare mandate. But since we got funded, there's been some new guidelines. It's now a Class 1 ACCHA guideline for shared decision-making for defibrillators. Medicare jumped on this, and then they said in their recent decision memo, for those patients identified, a formal shared decision-making encounter must occur using an evidence-based decision tool on ICDs. And then Medicare referenced our tool in their coverage decision, which is really cool. And you can see this is February 16th. This is from Google Analytics on our website. Turns out nobody looks at our decision aids on the weekends. But short of that, we're getting a lot of attention on our website. We're actually, as a group, kind of revamping and trying to think, well, now that this is happening, what do we need to do or think differently? Because we're a little bit out of our comfort zone or expertise with getting this much attention. So it's cool and it's not cool. It's great. As we said, we have this combined effectiveness implementation hybrid. We lost a lot of our ability to test effectiveness because now every control group is using the intervention. We actually went to Medicare and asked would they give a waiver for the 6 sites in the study until the time of their rollout. And they said, we had a call with 6 people from Medicare, had lobbyists from the ACC and the Heart Rhythm Society helping us on how to frame this argument. And they were really thoughtful. They said, gosh, we would really love to do that. And we wish we'd given some freedom for research in our coverage, and we're going to think about that in future coverages. But if we were to do that now, we'd have to go through a whole new public comment period, and we can't do that. And so it is a lesson, I think, both ways. But but what we lost in effectiveness, we gained in our ability to study implementation. We're now ready in administrative supplement to not just look at these 6 sites, but look at how all the sites are adopting these and what are their attitudes around that. And so Medicare's been doing this for a few things: lung cancer screening, left appendage closure devices for atrial fibrillation, and now defibrillators. And there's some writing on the wall that some other procedures are coming down the pipe as well. So I'll stop there. I meant to go about 20 minutes. I went about 25, so I can give it to Larry. And then we'll have some time at the end for some questions.
Great. It's thanks for having me. I know many of the people around the room, but it's nice to see some new faces. And if you ever want to reach out to me, we have a very collaborative environment. We believe in team science, and the work that Dan talked about and then I'm going to talk about really doesn't go happen unless we're really working together. So I'm going to talk about left ventricular assist devices. We've operated in the cardiovascular space in part because it's a common disease, the most common reason for disease and death in the United States. But the other is that some of these devices in cardiovascular disease, I think, highlight really some of the challenges around shared decision making. So Dan talked about defibrillators, and I think as a cardiologist, defibrillators are really interesting because most of the things that I try and do for patients try and treat their disease, and that often makes them not only live longer, but it makes them feel better. And defibrillators just abort death. They don't make you feel better at all unless you just get a little peace of mind from that. And that really kind of challenges decision making and how patients approach this, because it's like, well, do you not want to drop dead or die in your sleep? But by the way, we're going to do all this stuff to you, and you're not going to feel any better, and you have heart failure, and you're kind of miserable. And that's unique. Left ventricular assist devices are basically partial artificial hearts. They've been working on artificial hearts for years and years. The first real artificial heart that was put in a patient was Barney Clark. I remember back in 1983 when I was a kid watching it on television. And he lived for a few months in Utah. And then there was some work to try and get artificial hearts to work better. And what happened is around the late 90s, this Heartmate XVE device was made. And rather than take the heart out and put a new heart in, they went with this left ventricular assist device, which is basically a pump that you put next to the existing dysfunctional heart. And this XVE device was pretty revolutionary because it was the first time that they could put it in a lot of people. And what they found is after a year, if you didn't get the device and you were very sick from heart failure, after a year, your chance of being alive was less than 50%. And if you got the device after a year, your chance of being alive was significantly above 50%. So this kind of made artificial heart technology mainstream. And so those of us who take care of patients with heart failure that were very sick, all of a sudden it started to challenge whether those patients just died from their heart failure or whether you're going to undertake this massive therapy. That was great, except that the XVE device was not great. It had a lot of side effects. The stroke rates were in excess of 20% at a year. The device fell apart after 2 years. You needed another major cardiovascular surgery. And so that was a step forward, but a very big step forward was basically in 2008, the second generation of devices came out. This was called the Heartmate 2 device. This device basically is much smaller, uses a propeller that's in the middle of it, and this device can essentially last for, we think, 20 years. It hasn't even been around that long, but you can get it, live with it for a long time, and the side effects and complications were much lower. And so all of a sudden, people started using this, and now we're into the third generation of devices. There's two companies. Medtronic makes an HVAD device, and Abbott makes a Heartmate 3 device. And these devices are a little bit better than the second generation device, but are making this mainstream. This is one of the registries that looks at the use of these artificial heart devices around the United States and the world. Most of them are put in the United States. And as of 2016, in this registry, they had 15,000 devices, but we're up to about the implantation of 3,000 to 4,000 devices in the United States per year, which is significant. And that is now more than the total number of heart transplants that are done in the United States every year. So that's kind of the clinical background. The reason that I think this highlights shared decision-making so well is that the trade-offs for LVADs are quite complicated. And this word DT, or these two initials, stand for destination therapy. And these devices were initially often used for patients who were waiting for a transplant, couldn't wait any longer, and you put the device in just to temporize them, try and stabilize them so they didn't die so they could get a transplant. And now, more of these devices are being used in people who are not transplant eligible. They're too old, they have other problems, they can't get a transplant. And so you get one of these devices and you live with it for the rest of your life until you die. If I were to offer you one of these things, the problem is that this is a high-risk, high-reward situation. So this is not like ICDs. These things, when they work, they really work. So the bottom part of this graph here on the Kaplan-Meier curve is the survival or mortality curve for people in the original XVE study that I mentioned back in 2001 and how quickly they died. And you can see by 2 years, basically only 8% of people are alive. So basically, if I'm offering you an LVAD and we still offer this to the same population, I'm offering it to you because you're dying. And I often tell people, they'll say, well, I don't want an LVAD, one of those things, unless I absolutely have to have it. And I say, I'm not offering it to you because it's fun. So these are patients who are essentially dying. They feel terrible and they're likely to die soon. And the question to them, are they okay with that? Or do they want to undertake a major procedure? One of the things I think that's impressive, is that if you think about number needed to treat, we often talk about, this is really, if you talk about number needed to treat, we often say, if I give you a statin drug after a heart attack, the number needed to treat to save a life after 2 years is 50, right? The number needed to treat here is that if I take 2 people and I give them both an LVAD, in 1 year, I will have saved one of them. So the number needed to treat to save a life at 1 year is actually less than 2, which is pretty amazing. The only other thing I can think of is like treating children with ALL in pediatric cancer. So it's pretty impressive. The problem is that these things don't always go well. So sometimes they save your life, and sometimes they don't. So about 10% of people have stroke in the first year. A lot of people have bleeding because this propeller that's in the device is like a wearing blender, and it blends up your clotting factors and your platelets, and it causes a lot of bleeding. So our gastroenterologists love this because we're always calling them like, can you fix this LVAD patient because they're bleeding to death? And then the other is there are burdens with this. So people say, what do you mean I'm going to be hooked up to batteries? Because these are electrically powered motors. And this is what it means. They actually have a drive line, a power cord that goes to the device that's implanted in the chest. They tunnel it across the abdomen, and it exits, and then they have to take care of that. They have to plug it into a controller, and then they usually have 2 batteries that last all day, and at night they plug into the wall. And that is scary for people, and it's burdensome. And oddly, I have many patients who say the thing they miss the most is swimming. I'm not a swimmer. The other thing that's interesting about this is I cannot tell you how often people talk about that what you're trying to trade off is quality versus quantity. I have a patient who's dying from heart failure, and they often are told, well, do you want to go to hospice and have a good quality of life death, or do you want to get an LVAD and maybe live longer? And that is not actually the question that you're asking. What you're asking is, do you want to have an aggressive course or a non-aggressive course? And I thought this was well described actually in an NPR article that covered the work that our group does. So they went through the study that we published, and they said, this is what this is like. You have really bad heart failure and you're dying and you're sitting in the ICU and you have $1,000. And I'm going to say, do you want to place a bet or not? So you can bet that $1,000 and you can get an LVAD, and there's a good chance you're going to double your money. You're going to do okay with your LVAD, you're going to feel better, and you're going to live longer, and you're going to be in much better shape. The problem is when it doesn't go well, these are like the worst deaths possible. So instead of going to hospice to make you comfortable, see how things go, you die peacefully, a lot of patients die in the most intensive ICU, prolonged death possible. And I think that's part of the motivation for why I got into this, and some of the other people really reached out to Dan, is that we were tired of seeing this and people saying, you never told me about this. We didn't expect this to happen. We were told this was going to be better. So ultimately, I think this is also a very preference-sensitive decision. Depends on who you are, what your chances are, what your goals are, what you're trying to avoid. The other big problem that we found in this is that these devices are made by industry. They're advertising these devices, and they're complex, they're new, people don't really understand them. And so people are hungry for information. And the industry companies that were making these devices, they provide marketing materials, which is fine. That's what they're supposed to do. The problem is that's the only material that was out there. So this is Art. He's 86. This is an ad from the Abbott company that makes one of the devices. And they have a video where Art's driving around on his four-wheeler, like literally on the border of Canada in the snow, talking about how great his device is. And Dan mentioned earlier, that might be a little influencing. You know, some people, that's what happened, but that's not the usual. So we actually, our group, when we first started getting into this, this was really Dan's idea. He took one of our medical students who wanted to work with us, sent him to the library and said, work with the librarian and find everything you can about LVADs and what information is out there on the internet and at programs and from companies. So we got that all together, found 77 materials back in 2014, and basically showed how incredibly biased they are. They all talk about the benefits of getting LVAD. There's all these horrible things that can happen, and only half of them even mention a single bad thing that might happen if you get an LVAD. None of them really talked about the burdens and lifestyle changes, and nobody talked about what was the alternative. The 1% mentioned palliative care. That was our device, our decision aid. So Dan showed theoretically what making the decision aid looked like, but this was for us. So we started out making a paper decision aid. We went through at least 20 iterations of this. We had V1, V2 on the files. We got up to V20. And this ended up being an 8-page document. And then once that's all fleshed out, then we do the videography and go out and get different people who represent different clinical courses of what might happen when you get one of these devices. And what we found is that people really like the video. You know, I talk to people, they don't really want to read a book about what it's like to have an LVAD. They want to talk to somebody who had one. And the problem that was happening at programs around the country is that I was just on service a couple of weeks ago, and we're talking to a patient about LVAD, and they said, can I meet somebody that has an LVAD? And the nurse says, oh yeah, well, like, you know, John Doe's in clinic today. He's doing great. He loves to talk to people about how great his LVAD is. And so they would march people around. And one of the things we found is that we can help satisfy that desire for people to see somebody with an LVAD and talk about it. But we can control that in the video by getting a lot of different people who've had different experiences. And we can grab people who had bad experience, somebody who didn't get an LVAD, and maybe somebody who's dead, and we talk to their spouse. So that, I think, is incredibly powerful and meets the need that people have when they're talking to you. So we finished developing Decision A. We're pretty happy with it, and we went to Corey to get money to do an implementation effectiveness trial. And this was funded from 2014 to 2017. And we wanted to see whether a decision aid that we implemented into programs was effective at improving decision making. So this again was a Stepwedge Design. We took this and used it now in the ICD trial. A couple of things about this. The first is that everybody starts in the pre-period. And that, I think, is important if you're really focused on implementation, because you've got to figure out what everybody's doing. So if you start your study and half of them you immediately randomize to something else, you don't have a lot of time necessarily to understand what's the baseline in terms of implementation. And then the second thing we did is we actually didn't totally randomize this. We said, we know this is going to be a problem. We know a lot of people are nervous about doing this. So we randomized our own, we non-randomized. We put our own site into the trial first, and then we randomized the other sides to stepping over to this. The other thing that Dan didn't mention that's really helpful if you're thinking about doing a study like this is that the stepping of the wedge of going into the intervention is helpful operationally, because I went to every site when they rolled out and went there and gave a talk and said, this is what we're doing, and met with their people. And if you're going to roll out all your sites at the beginning, or half your sites at the beginning, or all of them midway through the study, that's a lot of plane travel all at one time. So this allows you to kind of space out your work of implementation if there's a rollout period, which I think was really pragmatically kind of helpful for us. The other thing is it gave us a little bit of chance to tweak it as we went along and kind of get better as we went along. And I think that's okay if you're really just trying to learn how to do this. And then finally, everybody finishes in the intervention period using these. One of the problems Dan mentioned, but I want to highlight, is that if you really want to test effectiveness, people talk about this being a randomized design. This is not a randomized design. It's a quasi-experimental design, because what happens if halfway through the study, Dick Cheney gets an LVAD and he says it's great? Well, all of a sudden now, before that, nobody knew what an LVAD was. After that, everybody does. And the second half of the trial is when most of your patients are enrolled into the intervention. So you got to recognize that. Diane Fairclough told me a lot about the statistics of how you're able to adjust based on the phasing. Unless you're doing like a 10 million person study, I don't believe you can adequately adjust for time trends. The other is that this is a fairly complicated data collection. I'm just going to go through this just to show how tricky this is. So one of the things is, when you get people enrolled into the trial, one of the things that's really nice about LVAD is it costs about $500,000. So we don't even get to ask somebody and evaluate somebody for an LVAD until we get insurance approval. So if I have somebody who comes in and they say like, well, I feel terrible, and I'm like, wow, you look like you're dying. And we talk and we say, gosh, maybe we should consider an LVAD. The very first thing we do is the green screen, which is, we don't tell the patient, we call up their insurer and we say, hey, would you be okay paying for an LVAD in this patient? And when they say yes, then we're like, okay, boom, marshal all the resources. And what we did is we just said, when the insurance company says, or when we ask the insurance company whether they'll say yes, boom, we enroll the patient at that time. And that was actually really helpful for this study. So we get initial formal DT evaluation started based on the insurance request. We do the enrollment and the baseline survey 1. And then typically, if you're in the hospital dying of heart failure and I say, I want to consider you for an LVAD, all of a sudden for the next like 72 hours, everybody's coming in and talking to you. They're doing ultrasounds, make sure you don't have cancer. They're trying to do education. And we put the decision aid in that period. And then we follow up, the intervention was in there, and then we follow up with a baseline survey 2 at about 3 days to kind of hear, well, how did this process go for you? And then we say at a month, how are you doing? And ideally, a lot of people, if they were going to get an LVAD, would get it during that period. And then we looked at 6 months and we did medical record review at a year. So the majority of patients undergo open heart surgery at that period with a 1 to 5% risk of death. And a lot of these patients are quite sick. And one of the things you do struggle with is, I think as a researcher, you're like, wow, I really want to get a lot of information from these patients, right? So you get all your questionnaires, I need my PHQ like 9, and I need my like, satisfaction scores. And like, then we ask our research assistants, we're like, go enroll this patient. And they walk in the room, the guy's like, corked out in ICU, and family's crying. And so I think we have to kind of be very practical. And so we took the amount of data that we wanted to collect and we cut it down by half, essentially, before we really started the study. So we enrolled 248 patients from 385 eligible from 6 sites over this course of this period. So it's a greater than 50% enrollment. Some of these patients are extremely sick. A quarter of them got enrolled out of the ICU, and I think that is pretty impressive. So, we had patients like this guy, Don, who we were able to get him to do videos with us, but these people do want to help, even when they're maybe at the end of life. We did the intervention delivery. All the sites participated. We went out and did this training, and then basically 90% of people that were in the intervention period said that they got the intervention. So we clearly worked hard to get buy-in, and people got the decision aids. And then we measured how it went. So our primary outcome is decision quality. Dan said I would give you a little more data on this. This is the way that Dan explained this to me. I remember 9 years ago, like today. He was like, what is a good quality decision? Well, a good quality decision is that you know what it is that you're deciding about, and you end up choosing something that matches your values. So the decision quality is the extent to which a medical decision reflects the considered preferences of a well-informed patient, okay? It's messy, though, when you try and quantify this and collect data and put it in the paper, and JAMA says, we don't understand what the hell you're talking about. We're sending you to JAMA Internal Medicine. So when we did this, we basically, you have to test people, right? So we gave them a 10-item question, or test questions about LVAD, and we said, like, do you know what this is, and what's your other option? And so people went from getting basically about 6 out of 10 questions right to roughly 7 out of the questions right. And so we did improve knowledge a little bit. And then what we did is we found that the values in this situation really came down to that: are you an aggressive person and you're willing to go through surgery and a lot of stuff, or are you like, there's worse things than death, I don't want to see you anymore, I'd really like to go home, and I don't like doctors. And then we said, if you said, I want to do everything I can, and you chose LVAD, that's concordant. And if you said, I hate doctors, I hate the hospital, I'm okay dying, and you chose no LVAD, then that's concordant as well. And discordant is when you chose the thing that didn't match up. And what we found is that in the intervention period, people chose something that was more aligned with the values that they said that they had. So this was a positive study. The other thing is, a secondary outcome is that in the control period, 8 out of 10 people that were evaluated for LVAD chose to get an LVAD. And in the intervention period, only about 5 out of 10 people chose to get an LVAD. Now we're talking about like almost $500,000 worth of therapy here. This was seen as very interesting. That in the intervention period this went down. We tried to adjust this. The adjustment didn't change it more than 1% because the differences between the groups weren't that big. I worry about the time trends that I mentioned to you and what the sites were actually doing, because you're affecting the sites. The other thing some people are worried about, did we scare 26% of people away from a therapy that probably has a lot of benefit for a lot of them? And the biggest concern is that I get paid largely by how many LVADs we put in. And I think people are very curious about this, but whether you think this is a good thing or a bad thing really depends like where you sit. Are you a payer? Are you a health system? Are you Kaiser? Or are you the UC Health? And this is very interesting. We also enrolled caregivers in this study, and there are not that many big caregiver prospective studies out there, especially in something like this. And LVADs are really interesting because we will not implant an LVAD in you unless you have a designated caregiver. Some people come to us, they say, I'll just live in a nursing home, and we say that's not the way it works. So this is it has a lot of effects on caregivers. We enrolled, the majority of patients had a caregiver enrolled in the study, and we asked them about knowledge, which improved but not quite as much. We asked them about, what do you think your loved one wants, or what kind of person are they, what did they choose? That got a little bit better. One of the things that's really interesting, I think, is that we asked people what their decision conflict is. And if you look at that systematic review Dan showed of patient decision aids, the most common primary outcome chosen for studies of decision aids to see whether they're good and effective is whether they reduce decisional conflict. So if you ask me, do I want to know that or not? And I'm like, I don't know, I'm really high conflict. They would argue that if you ask me, I say, I know exactly what I want, I feel really good about it. I saw Dan's decision aid, it's awesome. I'm peaceful, That's what a lot of people say is good about this. And I actually had a theory before we went into this. It's part of the reason we did not pick this as the primary outcome is that people are dying of heart failure, and what were they getting? Their surgeon would come in the room and say, don't worry, I'm going to take care of you. Everything's going to be okay. Here's the brochure from the industry. Here's Art, who lives in northern Minnesota. He's driving around on his four-wheeler. He did great. Do you want to know that? And people's decision conflict is pretty low. They're like, yeah, sounds good. And then we give them a decision aid, and we're like, you're in a tough spot. 20% of people die. It's a horrible death. Your caregiver has to take care of you. Strokes suck. You got a 10% chance of that. And then we asked them, how's your decisional conflict? And what happened in this study is it was about the same for the patients, but for the caregivers in the intervention period, it actually stayed very high. So we actually had a negative trial, except that I actually think we did the right thing. But is it okay to make people have angst about a tough decision, or are you really trying to make them feel like reassured? And I struggle with that in my own care. So, and then the last thing is 20% of patients were dead by 6 months in this study. And we enrolled a lot of caregivers. So we're looking at 6 months, we went back to the caregivers and said, so how's it going? I know Joe died, but we'd like you to fill out all these questionnaires again. But actually what we found is that if you approach this in the right way, bereaved caregivers actually can be a good source of information and actually want to help out. And one of our co-investigators and PIs in our group is Colleen McElveen. And this is a JAMA Internal Medicine paper. JAMA Internal Medicine is one of the top 10 medical journals in the world. And this is a study with an N of 8 because we went to bereaved caregivers and we said, what is your experience like when your loved one with an LVAD died? And they said it wasn't very good. We need to do a better job. So I think that's a good thing. I already covered these considerations. I just want to say that because this study went so well, and I think our team worked so well together, and we really engaged sites well, and our research, our PRAs, and everybody that worked with us, statisticians, I think this is a really successful study. And we went back to Corey and said, will you give us another $2 million to see whether we can get not 6 sites to use this, but all 173 LVAD programs in the country. This again was Dan's idea. He's much more ambitious than I am, and way more positive. And they did. So we just started a couple of months ago, actually working on how we're going to try and disseminate and implement this into as many places around the country as possible. Monica's here. She's leading the charge on this. If she looks like worn and haggard, it's because she's only gotten to 172 programs. She just can't get that last one. So anyway, but this should be a fun project, great opportunity to think about implementation. And then the last thing I want to say is this is like the most fun thing I do, and I wear a lot of hats around campus. And it's because the work is fun. You know, what we're trying to do is, I think, good. But a lot of it's just because the people are great. You know, we really work as a team. You know, Dan and I have both contributed in terms of dollars from a variety of sources, you know, millions of dollars to the work that we've done over the last decade. And we share, like, we literally, like that kids book that says we share everything. I mean, we really do share everything. And hats off to Dan for, you know, being so easy to work with. But the other thing we do is, you know, like Jocelyn Thompson, is one of our research assistants. She drove a lot of this research. Like, I'm busy over in the hospital, and she did a lot of this, and so she's the first author on a lot of the papers. And I've had many people come to me and say, why would you let a research assistant be a first author on a paper? And my answer is, because I have a lot more papers than you, because I allow that to happen. And I have a lot more senior author papers than you do. So, you know, I think we really have had a great group, and I want to make sure that everybody knows how collaborative that is. So thank you.
You've got 5 minutes for questions. If you do leave, please make sure to fill out an evaluation. And if you haven't signed in, please make sure to do that. And
it's got the sign-in sheet, I think, over there somewhere. Yeah, there we go.
So,
I'm just curious if the devices will have come after you. I would think they'd be very threatened by this work.
Yeah, I mean, you know, Dan's dealt with this a lot with the ICDs. ICDs are actually put in a lot more people than LVADs. So I think it's a little bit different. The other thing is there's been a ton of consolidation in the industry. So when I started doing this, I was working with Thoratech, who then got bought out by St. Jude, who got bought out by Abbott. And at some point, Abbott is a $65 billion company. And, you know, so that's one thing. It just kind of gets a little bit lost in that. The second thing is that these companies have to be careful, which is that if people start putting LVADs in everybody, and they have a lot of bad outcomes, they'll get shut down. They will have national coverage decisions from Medicare that lay the hammer down on them. And so they actually aren't totally against this work. They don't want an LVAD to go into somebody and have it be a terrible death, and then have that spouse get on Facebook and start an entire thing against it. So it's interesting. I think it hasn't been all positive. Mostly it's been like kid gloves. And then the other thing that's interesting is one of their tactics is that they will like ask people like me and Dan very frequently to be on ad boards, and they'll want you to be a consultant, and they really like, you know, keep your enemies closer. That's another thing that they do. So at the end of the day, the other thing is that I always am very careful. I mean, LVADs have helped a lot of patients. I mean, I was just talking about a 35-year-old patient who was dying, and I saw in clinic this morning and is doing great. So, you know, I don't want to villainize the industry. They've developed these devices, and the federal government doesn't develop them. It does basic research, and it does post-marketing research, but that's who's developing these devices, and they are great devices when used well. And so it's complicated, like all of life.
In your decision, you had put that they have all of these tests that they have to run, and then it seemed like the actual decision aid that you guys were using was done at the end.
It's actually, you were looking very closely exactly where that went.
Yeah.
Literally, our coordinators, so we have nursing LVAD coordinators, that's their job. They like introduce this, and they take care of the patient, they do the education, they take care of the clinic afterwards. Their favorite thing to do is, we get insurance approval, they go and they walk in the room, and they say, you know, we were talking about that LVAD thing, you got approval, we need to really sit down and talk about it. What I'd like you, this is what they'll say, so you're the patient, they'll say, what I'd like you to do is, let me see your iPad. They pull this up on their iPad, and they say, I want you to go through this 8-page thing, then I want you to watch this video. You should call your family and either have them come in and see it, or you can send it to them. And then I'm gonna come back this afternoon. Is 2 o'clock a good time? Can your spouse be here? And then what we'll do is then we'll sit down and go over this. So where they're putting this in is like right at the beginning. And actually multiple of them say, this is a big deal. They say, we really like using your decision aid because that conversation at 2 p.m. is easier and sometimes shorter.
Mm-hmm. Well, because I was wondering if you ended up doing it later after they've already started getting tests to see if an LVAD is appropriate, if that ends up, the ball's already rolling at that point, would it actually sway them to being like, well, I've already started this process?
Yes, and that's actually a great point. Dan made that point. My favorite example of this is John Spurtis, is a cardiologist in Kansas City. He does a lot of prognosis and giving people information around getting a cardiac cath and a stent. And they developed a really nice decision aid that takes this mathematical stuff and it puts in your exact risk and all this thing. And they were giving it to people, but where they're giving it to people is you come in for your cath, you're like getting your pre-op evaluation. They're going to take you to the cath lab in 20 minutes. And then when you sign your consent, now you have this really nice consent with tailored information. And it says, do you want to do this? The problem is that consent is not just bullshit because it's like legalese. It's bullshit because it happens 2 minutes before you're getting your procedure. And so they did this really nice work. They got a ton of money from the NIH. They did a big study. The study was negative. Because I think it's not because the materials are bad, it's because they gave them to patients when they were on the gurney right before they were getting rolled into this thing, like, hey, you got to sign this thing so I can do your cath that you're getting. So I think that's a really important point. It's harder though with, like Dan with ICDs, because I'll tell you who decides whether a patient gets an ICD. I'm a heart failure doctor. I refer to my electrophysiology colleagues. They're the barber. When I take a patient and I refer them to the barber for a haircut, they're usually getting a haircut, right? So the goal is to get the ICD decision aid up to people like me. The problem is that I don't do consent for ICDs. I don't put them in. I'm not the ICD doctor. So how do you take the informed consent that's been converted into a patient decision aid shared decision-making document from where it normally lies and move it upstream to a different visit with a different provider who doesn't do that? That is, I think, the challenge of Dan's study. That's why he keeps telling me to work on it. And I keep telling him, I'm really busy. I can't help that study.
You know, you're talking about framing. Have you had any feedback from anyone or any conversations around the framing of it being an approved procedure through insurance? Because I can see how that conversation sounds like, congratulations, you've been approved, or it's a positive thing, you've been approved, now we can move on. Does that seem to have any impact on whether or not people think it's like a...
Yeah, I probably didn't say that right. We actually have a two-phase process. So you actually need insurance approval to do an evaluation. Like I can't order all the studies that I would only do because I'm evaluating you. And so that approval isn't like, you've been approved to get an LVAD. The insurance company hasn't even done that. They said, you've been approved for an evaluation process. So actually when we go in the room, we don't usually say that. We just say, our team talked and we got some information, talked to your insurance. And I think we're gonna go ahead and do an evaluation to see whether this would even be an option for you. And a lot of that's gonna be tests and people coming and talking to you, but I also wanna start out letting you know more about it. Here's this decision aid. We need to do some education this afternoon. That's probably a little closer to the way it is. All right, thank you.
All right.